Conference will now be recorded.
Hi, everybody, and welcome to the AnCan High Risk, Recurrent, and Advanced video chat for Monday, November 17, 2025. My name is Len Sierra, and I'll be your moderator for today with a little help from my friends and fellow moderators, Rick and Dr. John. And just want to say that everything that you hear tonight should not be construed as medical advice. This is just a discussion. And I guess that's it. I'll turn it over to you, Dr. John, for our sponsors.
Okay, we have several sponsors that help to make this possible and don't require us to pitch their products or anything like that. They are Bayer, Johnson & Johnson, Myriad Genetics, Helix, Blue Earth Diagnostics, Foundation Medicine, and Novartis.
Thank you, John. All right. Now, Barbara and Joe, turn your mic on.
Hi.
Hello.
Can you hear me okay?
All right. I'm gonna ask you a few questions, Barbara, just to keep us on a chronological track. So don't jump ahead, okay?
Okay.
All right. Here we go. So, Joe, how old are you?
75.
Okay. And where do you live, Joe?
We're in Laguna Hills, California, Orange County.
Very nice. I guess Rick knows how you heard about AnCan, so we don't need to go there. Do you recall what you?
I don't know. I don't know, Len.
Oh, okay. Well, then let us know. How did you hear about AnCan, Joe and Barbara?
At the prostate conference in September.
PCRI.
PCRI. Very good.
Yeah. Somebody was there from AnCan.
Yeah, we talked to them at the table.
Okay, thank you for that. And so, Joe, when were you first diagnosed?
Oh, 8 years ago.
Okay, and at that time, do you recall your Gleason score?
It was a 4 and a 6.
4 plus 3.
4 plus 3. 4 plus 3.
4 plus 3. And do you recall?
Go ahead.
Do you recall how many cores were positive from your biopsy?
No, quite a few.
No, there was about the 4th biopsy, and before that they had not had any indication. So I think this was 12 when they found it.
12 biopsies?
12 cores.
12 cores, and you don't know how many of those were positive?
I thought maybe 4 of those, or 2 to 4.
Okay.
But it's 8 years ago, and no, I don't exactly remember.
Okay, so 8 years ago, you were 67. Yeah. Okay. And which doctor did you see, and at which institution?
At the time of the operation, or now?
Oh, okay. So you had a prostatectomy.
Prostatectomy, yeah. No, it's a recurrent problem at this point.
And
Okay.
recurrence. I mean, he had radiation, a prostatectomy and radiation, and he did have invasion in the seminal vesicle.
Okay. So they did an MRI?
Yes.
Okay. And no other locations of the cancer other than the prostate and the seminal vesicles?
They claim there was nothing in the lymph, and it didn't go beyond the confines of the seminal vesicles and the prostate.
All right. And so your first treatment was prostatectomy, and then you had a PSA recurrence after that, and so you had salvage radiation therapy. Is that right?
No, there was no indication. They just suggested, because of what they considered to be an aggressive cancer, that there be radiation therapy right thereafter, 2 months after, for about 18 weeks.
So it's been 7 years. We've been 7 years cancer-free with no indication of PSA rise. So only 3-4 months ago did we get an indication that the PSA is now detectable. It's about a 0.149. And that's been the case for about 4 or 5 months.
Okay, and was there any other PSA before that was positive?
No,
that was the
for
first
7
one.
years it was
It
undetectable.
was 0.
How often were you checking the PSA?
Every 6 months.
And then for every 3 months, then 6 months, then 1 year.
Okay. All right, so under whose care are you right now? Do you have a medical oncologist?
Yeah.
Yes, at Kaiser,
Dr. Lowe.
Dr. Lou or Lowe,
Lowe.
depending on how you pronounce it. Spelled Lou, but pronounced Lowe. And then Dr.
Okay.
Schultz has a second opinion.
Okay, and what are they recommending you do at this point?
Every 3 months of PSA, which I'll do
Okay.
next.
So they're just gonna keep an eye on it. Right.
Yes.
But
Okay.
I have 2 questions, unless you want to ask some more questions.
Yeah, I just have one other question. Did you guys have any genetic testing?
No,
Genome sequencing?
no.
Okay. Any cancer in the family, Joe?
A maternal uncle
And your brother
and the eldest brother.
has
And
Prostate cancer. Sorry, prostate.
cancer. And are they still with us?
The uncle was much older and died 20 years ago, and my brother is recovered, we think.
Okay. And when was he diagnosed?
like 30 years ago.
Yeah, almost 30 years ago. Yeah.
Oh, yeah. So he's pretty much clear.
And
Okay.
he had a recurrence also, but they just radiated him. He hadn't been radiated initially.
All right. So I'll ask you this question. Maybe one of the moderators or one of the attendees can answer it if you can't. Is your Dr. Liu, is he a specialist in treating prostate cancer?
A medical oncologist. He's a generalist, and so that's why we went to Dr. Schultz, who's the prostate specialist.
Oh, Schultz. Oh, okay.
Yeah.
I missed that. All right. So
We have 2, and I'm working on a 3rd.
okay.
Because Kaiser,
now,
we're
Barbara-
trapped with Kaiser for now. But so far, the care has been really good.
Okay, Barbara, you said you had 2 questions for us.
I do. And the first is, he's going to have a PET PSMA as soon as the PSA rises. I'm sorry because I've been doing so much research on this, and so I just want to ask some questions of you guys who have so much experience. So my question is, the first thing, if the PSMA PET shows some involvement with the lymph nodes in the pelvic, in the pelvic region, they want to go in and just radiate the hell out of the pelvic region. My question is, do you know that the chances of lymphedema are 30% for prostate cancer radiation? And no one seems to talk about that. So if he gets radiation, I don't think they should touch more than 1 or.
Oh, we're getting ahead of ourselves here, Barbara, because they haven't even done the PET scan yet. I mean, suppose they only come up with 1 or 2 or 3 lesions in the pelvic lymph nodes. They would probably, or you should ask if they would.
She's frozen.
Yeah. Okay. I was going to say they should consider SBRT before. But should I wait for them to come back, Rick? What do you think?
We'll put a message in the chat window, and we may just have to go on and then come back to them because they'll figure out pretty quickly that they're frozen. Let's write a message in the chat window and You know, as soon as we start with the next person, they'll unfreeze. You know that, don't you?
Of course.
Yes,
All right.
let's go on to the next people, and then we'll just ask them to hold off until we're done.
Do we happen to know their last name so that I can
Yes, it's
keep them
yes.
from other Joes?
I'll give it you afterwards. You know, I'll give it
Thank you, Rick.
afterwards.
Okay.
Send me a note.
They're back.
Well, how
They're
about
Sorry.
that?
It just went black. We got stormy weather here. So was my question clear? What do
Yes.
you guys think
Yes.
about lymphedema?
When you lost us, I was trying to answer that question, but first of all, I don't know what the statistics are personally. All I can tell you is in our experience in this group over a period that as long as I've been with this group, which is over 10 years, lymphedema has been pretty rare for guys who had radiation to the whole pelvic region. Rick or John, would you want to chime in on that? Or
yeah, I would say we see it less than 5%. We do definitely have people that have suffered with lymphedema, but it's really, really rare. And
Mostly it's
usually there
after
are other
mostly
issues.
it's after the prostatectomy if they take 1 million lymph nodes out.
Right.
You know,
This was these are NIH studies I'm reading.
Well,
So
Go
but
ahead,
I'm so
Barbara.
glad to hear this. I'm so glad to hear this.
Okay. Now, the other thing I was saying when you lost us is that you're getting ahead of yourself here because you're already thinking about what are they going to do if they find pelvic lymph nodes. It could be that Joe only has maybe 1 or 2 or 3, in which case it's highly likely that they would want to do what we call SBRT radiation, very targeted metastasis-directed therapy, another name for it. So there's even far less possibility of lymphedema if they do that. But so you should just, sit tight, wait till you get the results of that PET scan, and then, we can talk about it then.
Okay. But SBRT is still radiation though, isn't it?
It is, but it's very targeted. It would only be targeted. Let's say you had 2 lymph nodes. You're right, 2 centimeters in size or less. They would just target those 2 lymph nodes. They wouldn't do the whole pelvic region.
Okay.
A lot
And
less.
so it's very rare. You haven't really encountered much lymphedema in prostate cancer patients then who've had radiation.
Right.
No.
I had massive radiation to my whole pelvic region. I never had lymphedema. As Dr. John mentioned, that's more likely to happen, I believe, when they surgically remove, 10, 20 lymph nodes in the pelvic region.
Right. Yeah. Right. Oh, thank you very much. That really helps. I really appreciate that.
Sure. Anybody else want to comment?
Yeah, I'll just chime in, Len. I agree with you. Lymphedema is much more of a problem post-surgery, anywhere in the body, not just prostate. I'm really not familiar with it being that big of a complication after radiation.
For lower body, which is
Correct.
really hellish. Yeah. Okay.
Oh, I see. We have a couple of hands. Thank you, Dr. Alfredo. Jim Marshall, go ahead.
Yes, Joe. Are you, by chance, a veteran?
No.
Okay. Thank you very much.
And Larry in Alaska,
Yes.
what have you got for us?
Thank you. I was just wondering how recent are those studies that cited a 30% lymphedema incidence?
They were about last year. NIH did a study of a whole bunch of studies that have been done on post radiation prostate cancer patients, and they had and and they had anywhere from 9% to 29% of men who, you know, had this as an occurrence after radiation. Apparently, you know, it's really a sensitive thing. You can touch 1 or 2 or 3 lymph nodes, and that can actually start the process of fluid retention. I was just really shocked to read that. But Mark Schultz did a video on it and said it was very rare. But I'm just wondering if he's looking at the studies, the NIH studies. And I saw it in several other places where lymphedema studies had been occurring. Okay, but thank you.
All right, Tony Fig, what have you got for us?
Yeah, I was wondering if you took a look at how many people were in the studies for one, just to make sure it's a large enough group.
No, and it wasn't.
At age 76, I had radical prostatectomy, and the surgeon removed 31 lymph nodes. He thought they were questionable, but they were all non-malignant. And I did have full pelvic bed radiation and no signs whatsoever of lymphedema in any of it.
That is really, and you're right. They were smaller studies, maybe a couple hundred. So, I'm really glad to hear that. I'm glad you don't have any issues like that too. Thank you.
Go ahead, Dr. John.
You're muted, John. Unmute.
I'm sorry, guys. The PSA that you mentioned that started off this recurrence was 0.15, and it was back in July. So I kind of hope you've had another one since then.
Right.
Have you?
Yes. Yeah.
Same reading.
Okay, thanks.
0.149. Yeah.
Yeah. And what was your PSA when you were first diagnosed?
I think it was 30. 30.
I think it was 19, but Barbara thinks it was 30.
No, it was 30. I remember.
Okay.
I take notes on all this stuff.
Okay, that's fine. I just wanted, we ask because some people don't make much PSA, but if your PSA level was around 30 at diagnosis, then that's not your case, but that helps us to interpret what it is right now. So, I think the bigger issue for me is how you're going to proceed with treatment. Clearly, you're moving slowly, so that's a good thing. Kaiser is not great. So in Southern Cal, we don't really know any good medical oncologists that tend to specialize in prostate cancer for Southern California. You figured that out, and you have you brought Dr. Schultz on board. He's fine, I think. Probably would not be my choice in the Southern California area. I think there are other choices. There's a couple of good people in Los Angeles. There's good people in San Diego. And I think that we can, we've got a couple of names around where you are.
Oh, that'd be very helpful.
Yeah, there's a woman is she at City of Hope?
City
in
of
Orange
Hope?
County. Well, I'm talking about Orange County, City of Hope.
Okay, yeah.
I'm not talking about Duarte. Lou, another Lou. I can let me see if I can find her name and put it in. But a lot of people seem to like her. I don't think we've got anybody on there from the area, but she's gotten good marks, and she'd be local to you. So that's definitely one person.
Okay.
That's Dr. Lou at City of Hope in Orange County.
Yeah, and that's right.
Let me just I think that's right. Let me just see if I can find her name. Yes, Liu.
Liu. Okay.
Liu.
Yes,
Okay.
and I think I may have a link for her too, which I'll look for you right now. But yes, so
Thanks.
I think that that's probably the most important thing. I mean, really, we could start looking at 0.15. May want to look. This is important also for Jim Stewart, who we're going to talk to in a minute. Probably not going to see much under 0.15. Some of the docs like to start looking at 0.15. And maybe you'll see and maybe you won't. It's probably, from our own experience, maybe 25 to 50% will show up at 0.15. There are probably guys in the room who are here right now who showed up at 0.15, and there are other guys who didn't show up to quite a bit higher.
Right.
So,
All right.
it's totally anecdotal, I'm afraid.
Okay, if we move on, we've got two more new folks. Are you, Barbara and Joe, are you guys all right for the moment?
Yes, yes. Thanks.
Yeah, I have, I'll come in another session for another question I have, so it's not urgent or anything. I tend to get way ahead of myself because I worry about everything, but that's okay. Thank you for your help. I really appreciate it.
Yeah, it was very helpful. Thanks.
Okay, so
thank you for coming.
The doctor's name is Sandy Lou, and I'm putting her link in the chat window for you. She is at City of Hope in I think they're in Orange. Oh, I sent that to the organizers and I meant to send it to you. I'll send it again. I'll put it in again and just click on, what you got to do is click on that and it'll open in your chat window, in your browser. There you go.
All right. So, Rick, do you want to go with Keith or Jim and Reno? Jim Stewart.
Let's go with Keith because he got bumped out last week. So
yeah,
Jimmy Reno will hang in for a couple of minutes, and also he's already heard a little bit about what we're going to say to him. But let's go with Keith.
All right,
Len?
Keith.
Len?
Hello.
Yeah.
Thank you.
It's John. If it's okay with you and Keith, I will do a very rapid presentation of his case and save you a little time.
Sure, thank you.
And then Keith, whatever I leave out, you just let people know. Keith is a 69-year-old man from Oregon, started in high risk last week. He was doing fine with PSAs around 3 until 2024 when he got up into the 5s. And finally, in the summer of 2025, he went and had a biopsy. He had 8 out of 12 cores positive for cancer and was given a Gleason 4+4 with no EPE or cribiform or PNI. He had a PSA that showed no cancer outside the prostate. He also got a decipher done in 7 of 2025, which scored a 10. He has a grid report, which I haven't read. He ran a MSKCC nomogram last summer and got a 67% prediction for 5-year metastasis. He has a father who had prostate cancer and a sister with breast cancer, but other than Decipher, he's had no gene tests. He's had no treatment yet. He's been seen at Heinemann Cancer Center in Oregon, and he's talked to a couple of patient oncologists. There is a plan so far to go for Orgovyx and RT, and he's here wondering if this is a good plan, if he should consider some other treatments, and that's as far as we got.
What's the stage of the cancer? Has it been staged as T2 or
Is it
T3?
T2C?
T2C.
Yeah.
And what part of Oregon are you in?
I'm in Southern Oregon, just outside of Ashland. So I'm halfway between Portland, Oregon, and San Francisco in terms of about distance.
Yeah, I'm going to be in Ashland in about 2 weeks. So,
oh yeah, well,
yes.
I'd be glad to chat when you visit.
Yeah, so I know pretty much exactly where you are. Okay.
So do you want me to cheat a little bit here or ask a question, or do you have more questions for me? I'd be glad to answer.
Well, why don't you tell us what your questions are first?
Okay. So, they just ordered the Orgovyx for me, and it's arriving in the next few days, so I can start on that. And this is, so it's a choice between Lupron and Orgovyx, I guess. And the doctor had never prescribed Orgovyx before, but I did some research and it seemed like a viable alternative. I ran it by her. She thought it'd be okay. I kind of know about it a little bit after studying, but anyway, the plan is for me to get on the Orgovyx and do that for 6 to 8 weeks or so, and then come in for radiation. And this is a plan that we have not done a precise timeline on yet, but it would be, she's recommending an IMRT, and that would be for, she said 28 sessions.
Mm-hmm.
This is through the Heinemann Cancer Center in Medford, Oregon. Mm-hmm. Some of my questions kind of, doing the Orgovyx concurrent with that radiation and then beyond for a certain period of time. She was initially saying 1.5 to 2 years, which I don't want to do that long. I don't know who would want to, but I would want to dial it back if I can. So my PSA was at 5.78 at the time of diagnosis earlier this summer. And then I had it checked again in August. It was 5.34, not much difference. The Decipher was actually very close to 10. It was 0.97, so very high. Father had it. Father had his prostate removed 30 some years ago. Did okay afterwards, survived for another 12 years, died of something else. Sister has breast cancer. So there's that genetic component. What I'm mystified by, and I could just ask a question of the administrators or experts here, is the PET scan. So I got this PET PSMA in August, and it showed all clear. So I was like, oh, okay, this means it's localized to the prostate. And then when I met with the radiologist, she ran the nomogram and she was looking at some other stuff. And she planted the idea in my head that this, what's called ECE, extracapsular extension, that according to this other data, it could very well be outside of the prostate.
Yeah. The problem, here's the problem, Keith. She's got this idea in her head, but she's not treating you accordingly. So if she really thought that that was the case, and it may be the case because you could have micro metastasis, she
Right.
shouldn't be doing 28 sessions of IMRT.
She should not.
She should not.
Why is that?
What she should be doing is SBRT to the capsule, either 2 or 3 or 4 sessions. Depends on your doctor and how they put it together. But let's say 2 sessions of SBRT, and then she should be doing 28 sessions across your pelvic girdle. And that's the gold standard. The gold standard was brachy plus IMRT across the pelvic girdle. The gold standard is definitely not 28 sessions of IMRT to the capsule. So she's telling you that you're higher risk. She's right. She's putting you on she's putting you on several months of hormone therapy, and she's right just to give you the ADT, which is the Orgovix. We believe that the right amount is somewhere between 18 months and 20 and 30 months or 24 months. It's not quite sure how far out, but I would not be going to this radiation oncologist. She should have offered you SBRT treatment to the gland, and then if she was concerned about anything outside the gland, she should have offered you IMRT outside the gland, and it doesn't sound like she's treating you anywhere outside the gland.
Okay, I'm sorry, I didn't quite give you enough information. After I brought up SBRT several times in 2 meetings with her, she said we could do SBRT. She didn't specify, but I think it seems like it's a 5-session treatment. And I was thinking
well,
that
see, that's the problem. It is a 5-session treatment, but it's not a 5-session treatment if you're high risk. And she's not treating you like a high risk person. And that makes me think she's not a prostate cancer radiologist. Because as soon as we know that you're 4+4, the first thing I would probably do, and do this before, is I'd get a second opinion on your 4+4. Because if you're a 4+3, her treatment plan is good. You may not even need the hormone therapy. You might be able to get away without it. Some do it, some don't. But if you're a 4+3, she's right. But if you're a 4+4, you're high risk. And if you're high risk, you have to be treated in a different fashion. And she's talking the talk, but she's not walking the walk.
Well, how do I mean, I have the biopsy information, the pathology report, and it's indicating certain data, but you're speculating that that may be debatable.
Well, I'm saying you should get a second opinion on it. That's what I'm saying. I'm not saying it's debatable or not debatable. I'm saying send that biopsy report to Dr. Zhao or send it to Dr. Epstein and have them give you a second opinion on it, because it will affect your treatment. And right now, all you've had done, I suspect, is just a local person in Medford, correct?
I had one other radiologist some months back. That was probably more like June or July.
Yeah, on your pathology. Let's just talk about your pathology.
Right. Okay. So.
All right. Now, I have a little bit, sadly, we have a little bit of experience of the docs in that Medford area, and they do need checking on.
I don't know how to go beyond them, though. Really.
Okay. Well, there's a couple of ways to go beyond. The first thing is call up whoever has your pathology, your biopsy slides, and you tell them you want to get a second opinion. Dr. John, can you pin the Dr. Zhao and Dr. Epstein's information to the top of the in the chat? And so you start working with a second opinion, and you do that first before you do anything more.
So even though I have out of the 12 capsules, 8 were positive, 5 of the 8 had a 4+4 reading.
you know, you want to verify.
Okay.
If you're happy and if you're happy and you feel that that's right and you don't want to check on that, don't do it. But then you're clearly high risk. And if you're high risk, you need to be treated as a high risk patient. And this radiation oncologist isn't treating you as a high risk patient. She's treating you as an intermediate patient, as a high intermediate.
Because of what I've suggested as her treatment for me?
Yes, based on the 28 sessions. But she's kind of mixing that up because she's also giving you hormone therapy, which is normally what we would do with somebody, how much hormone therapy has she said? Didn't you say 18 months?
Yes. Well,
so she's treating you as a high-risk patient with the hormone therapy, but she's not treating you as a high-risk patient with where she wants to put her radiation.
Well, she said she wanted to go outside of the prostate with the radiation somewhat. Yes.
So, well, but she's only giving you 28 sessions. So she doesn't have, so she's going to need 20 odd sessions for the gland, 20 to 25 for the gland. So she's not giving herself much room to go outside. The program doesn't sound right, Keith.
Okay. Well, I'm confused. Yeah.
Well, so am I.
Okay.
Because she's not, if I was sitting here or sitting next to you, I'd be saying, well, wait a minute, how many are we going to do to the gland? And how many are we going to do to outside? And where exactly are we going to put these outside? Since you don't really know, you don't see anything. It's not like we see something in the prostate bed. She's speculating.
Well, that's to be determined. I don't think we've worked out a specific, I'm trying to give you what I know so far, but we haven't I haven't gotten the specific radiation plan other than that generalized info I shared with you.
Yeah, but let me ask you, how's she going to decide where to put this outside if she's normally if somebody like you would get about 40 to 45 sessions.
Wow.
Okay, unless they did SBRT, in which they'd get somewhere between 2 and 5 sessions to the gland, probably in your case no more than 4, but a lot of these doctors do 5 because they can, and then they can bill for it. But if she did SBRT, she'd be doing 2 to 5 sessions for the gland, and then she'd be doing 20 sessions spread across your pelvic girdle.
Well, I can ask. 20, I mean, it's something. It sounds like yeah.
Okay, now are you sure she wasn't going to give you 28 sessions, which was 23 to the gland and 5 to the prostate with SBRT?
I don't know. I don't think it was a combination of those two.
Okay, well, you need to find out. That's what you need to find out. If she was talking 5 to the gland with SBRT and 23 outside and 18 months, then she's doing the right thing. But that's not what you were telling us. But then you said, well, she said she could do SBRT. So we really need to know. I would then go back to her and say, well, Dr. Roach, he only does 2 SBRT to the gland. She'll know who Dr. Roach is. And he only does 2 SBRT to the gland, and he does 20 odd outside. Why am I getting 5? Why am I getting 5 sessions? That's more radiation than I probably need.
Okay, so I don't know Dr. Roach, but so
she will.
I could look at. I'd be glad to use that information.
No, she'll know who Dr. Roach is because there's a scale named after him. He's at UCSF. Okay.
But so
Yes.
What you're advising is to look at an SBRT treatment 2 to 4 sessions to the gland, and IMRT approximately 20 that will go to the gland and outside.
Correct. I'm not recommending it. I'm telling you that's what I would do.
Yeah.
Okay, I can't recommend to you. I had very similar treatment, but I was a T3 and not a T2, and I didn't get it with SBRT because they weren't using SBRT back in the day. I got it with brachytherapy seeds.
Yeah,
and
would
that was
be another possibility.
Yeah, it would.
But
I mean, that was.
I'm getting into 3 modalities: brachytherapy, IMRT, and SBRT, and ADT. That's 4.
No, if you get the brachytherapy, you're not getting the SBRT.
Okay.
But you are in 3 modalities, namely SBRT or brachy plus IMRT plus hormone therapy.
So if I start the hormone therapy soon, this week, and then sort all this out, is that a strategy? It feels
well. It is a strategy. Yes, I mean because a lot of people will do 6 months. If you got 4+3 disease, you could do 6 or 8 months, and plus the SBRT. But Keith, we got to move on because we got one other guy, and we got a lot of people that need time, and I've taken up a huge amount of time to try and help you. Anybody else want to add anything to try and sort Keith out?
And do you want to ask him about veterans?
2 things. Keith, you're not a veteran. Okay. Prior to the ADT, request the testosterone test. Okay.
Yes.
To establish essentially a baseline.
Yes, we got that. I don't know
Good.
what the number is, but
okay.
All right, thanks, Jim. Good idea. Jeff Markey, go ahead.
Yeah, I put the link to getting a free genetic test in the chat. It's prostatecancerpromise.org with some stuff after it. If you'll take a look in there, it's a little bit up, but that way you can get a genetic test free. They will send you the kit in the mail, and you can mail it back. And in about 3 weeks, a geneticist will contact you. Just don't say you want your doctor involved, or they won't send it to you until they speak to your doctor. You can click on that link now and then just come right back here and check. You can go to your browser later and fill it out.
All right. While you're doing that, Keith, we're going to go to Jimmy Stewart in Reno. Go ahead, Jim.
Hi. Did you want to? Yeah, good to see everybody. I don't know. Did you want to ask me your questions? Or?
Yes. I forgot. You're new, so let's go through the questions.
Can I fill you in just a little bit, and just in the interest of time, and then Jim will have to come in with the details because I don't make notes on the low intermediate guys, but Jim and I started working together, or Jim and AnCan started working together. How long ago was it? About a year and a half ago now, right?
Well, actually, I started with that active surveillance group in 2023.
2023. The catch with Jim is that he's BRCA2 germline. And so we moved him from Reno, where he lives, Nevada. We moved him to UCSF. We got him to Dr. Carroll. Dr. Carroll decided that he should do surgery, even though he wasn't necessarily, he could have been an active surveillance candidate, but because of the BRCA, we went the surgery route, and he had the surgery, and now the PSA is starting to rise again. So that's the story in short. If you and Dr. John want to ask a few more questions to fill in, that'd be great.
So, okay, so what kind of treatment have you had so far, Jim?
For just the prostatectomy in May of 2024.
Okay. And your current PSA?
It's one of the concerns is that it's doubled. It was in February, it was 0.048, and then 2 weeks ago it came in at 0.1. So I think it's the rate of growth that caught everybody's attention at UCSF.
All right, but generally oncologists don't think about doubling times when the PSA is less than 0.1. So whatever happens from this point forward, you can start counting as your doubling time. Okay, now that you're at 0.1. All right, so you had the prostatectomy, no other therapy, no hormonal therapy, nothing.
None.
And they know your BRCA2 germline.
Yes.
Has there been any discussion about putting you on a PARP inhibitor?
Not yet. And I have an appointment next month with Dr. Munster at UCSF at their hereditary cancer clinic and their BRCA Research Institute. So I don't know if she's going to recommend something like that or not. I've read a little bit about the benefits of PARP inhibitors with BRCA patients. So I don't know if that's going to be her course, what she's going to suggest or not, or salvage radiation or what she wants to do at this point.
So let me just say, Jim, and we love Pamela, as you know, but Pamela shouldn't really be guiding your treatment. She should be consulting on your treatment, but you really should have, I would start off by going back to Dr. Carroll, who, by the way, is a great friend of Pamela's. And that's really, you know, if he says, well, you might be a good candidate just to start off with the PARP, then I'd be going back to Pamela and saying, what do you think about that?
Okay. Yeah,
But
Dr. Carroll's office. Oh, go ahead. Dr. Carroll's office, when they saw the results, they wanted to get an ultrasound to check and see what was left cell-wise in the prostate bed after the prostatectomy. And then they told me that Dr. Carroll isn't really seeing patients anymore. He does a couple of he's just doing surgeries right now, and I think he's kind of winding down a little bit. So I'm seeing one of his associates.
Who are you seeing?
Oh boy, I can't recall the name right off the top of my head, Rick.
Okay, try telling them that you're an AnCan guy and that, you know, we sent you to Dr. Carroll originally, and that you have your germline BRCA, and you'd really like to follow up with him initially, because he's not going to be treating you going forward. You're going to be seeing either or both a genitourinary medical oncologist and a radiation oncologist.
Okay.
And if there's a call to make on the PARP, it's going to be the GU MedOnc that will make that call. Dr. Agarwal is probably who I would send you to. And it's going to be in conjunction with talking to Dr. Munster, but Dr. Munster is a breast cancer oncologist, even though she does a lot of work with prostate and with pancreas, with BRCA mutations. It's not her specialty.
Okay.
How old are you, Jim? I forgot.
71 tomorrow.
Oh, tomorrow. Oh, my birthday was yesterday.
Jim.
Happy birthday. Okay.
So, I mean, should I cancel my appointment with Dr. Munster then at this point? I mean, I hate to take up her time. And
if you want to talk to her about all the other things that you need to be checking, or you just had your pancreas checked, which was solid, and everything else, no. You should be talking to her about all of your BRCA concerns. But
Okay.
in terms of designing a treatment plan now, I would start with Dr. Carroll. Say, look, Dr. Carroll did the surgery. I'd really like to see him, like to get his take on what he thinks, because he's got the experience with these BRCA patients and he likes to work with the BRCA patients.
Okay.
So you lean on him. If you've got an issue, we're happy to send him a note, but I think he'll see you and say, look, I just need to know who you want to send me on to for who should be monitoring me.
Okay.
And I would start with that. Maybe you can even get a phone call with him.
Yeah, I know in the past we've done some telemedicine consultations, so yeah.
And you know, just say and you know, ask him for his opinion on when would you innovate the PARP treatment. Would you start it early? Because maybe it is a good idea, just as Len says, maybe we try you
Okay.
with an early PARP treatment. And then I would definitely be asking Pamela about what does she think about an early PARP treatment. But I wouldn't go the other way, because you're likely to open yourself up to Peter saying, well, she's not a prostate cancer doc.
Okay. Very good.
Dr. John, you want to add anything?
Well, I wanted to clarify something. Is there only the one single 0.1 PSA so far in the
No,
whole field of
0.048,
non-detect?
John. He said 0.048, and then it went up to 0.1.
Yeah, and it's been gradually rising. For a while, I was on a monthly. It was gradually rising. Then they switched me to 3 months, and every time it's increased.
Okay, thank you. Just wanted to make sure we weren't just seeing a little blip.
Okay. Any other questions, Jim, for the
No,
group?
I got a ton of information, and I've got some pretty good direction on what to do. So thank you all very much.
All right, thank you. So that's our 3 new members. We can go next to Eric James. I think he
Okay.
got from last week. Go ahead, Eric.
Yeah, I can give you a little bit of update, I guess, in order for you to understand my question. So I was originally diagnosed in July with 4+3 Gleason, had an L5 MET. Also, what was in the original MRI report that it was worded so I didn't understand it is I also have a prostatic extension into the rectal wall. And on my original biopsy reading, it mentioned in one core, it said intraductal tissue. And I've since had my biopsy slides reread by Dr. Epstein. And he upgraded one core to a 4+4. And also information he included in his report was that a number of the other cores that were 4+3 had a high percentage of the 4 as well. Also, what he included he wrote in areas there's large cribiform morphology as well. So I have seen 3 doctors. I've met with Dr. Belosich in Miami. I also talked with Dr. Jang at Moffitt because I had an interest in the adaptive therapy. And also I've met with Dr. Courtney at UT Southwestern in Dallas, who will be sort of leading my my treatment. Dr. Belosich, he recommended I use him as a second opinion or to answer questions, but to get my actual treatment in Dallas. And all 3 of them gave me quite similar treatment suggestions, just with a slight difference, which is what I want to ask about. All 3 suggested probably 2 years of hormone therapy. And radiation following somewheres from 3 to 6 months of hormone therapy. And Dr. Belosic said if I didn't respond favorably to doublet therapy to add docetaxel, the difference of Dr. Courtney in Dallas, he just recommended adding the docetaxel to do triplet therapy. And last Friday, I began the Orgovyx, abiraterone, and prednisone. So my question for the Brain Trust is what you think of the idea of adding docetaxel or not?
Well, given that you're 4+4 plus IDC plus crib reform, probably triple might be a good idea. Whoever suggested that, I don't know. What do you, Rick, John? What do you think?
Well, it's a good question, and nobody knows for sure yet. But as best as we got so far, we look for a high burden of metastases in order to think about who should go for triple, rather than, at least so far, a high risk on the pathology.
Mm-hmm.
So I don't. I mean, it seems like a good idea to add docetaxel to a high-risk situation, but I think you'd be hard-pressed to find a justification in the literature. Rick, do you think?
Well, I just want to just clarify. We know you've got a lesion on L5. Where else do you think you might have other metastases, Eric?
There are no other metastases, and that's what was explained to me is the MRI said suspected rectal involvement, but what was pointed out to me is it says contiguous, so that's an extension. So it's not a metastases.
Okay, so I absolutely I agree with to some extent with what both have said. We really don't know. I don't know, although there may be research, and I'd have to look at it. How well IDC, large crib reform. Did you say you're IDC? I know you said you were large crib reform. Was it confirmed?
The initial biopsy report listed intraductal in one core. Dr. Epstein simply added that at the end. He didn't say as far as what cores it's in.
Did he confirm you were IDC?
Yes.
Okay. So if you're IDC and large crib reform, I really don't know how, just like Dr. John said, I don't know what the impact of chemo is. I'm also not a huge Courtney fan. I have to tell you that. And I am a big Belosic fan. So I have a preference. So if you're asking me, would you go with Courtney or would you go with Belosic? I would go with Belosic. Because I don't like the way I've seen Courtney treat men in the past. I haven't been comfortable with the way Courtney has treated them, but he's a very reputable doc. He wouldn't be my personal choice based on some anecdotal cases of men that he's seen. Now, I would probably go back to Dr. Belosic and say, Dr. Belosic, do you think that large crib reform and intraductal warrants adding the chemo? And if he says no, I would not do the chemo. What second line anti-androgen are they talking about starting you on?
So I'm on Orgovyx and abiraterone.
Abiraterone. Okay, fine. So that would be how I would approach it, I think. I mean,
Okay.
you know, they're both good docs, but it's a tough one. It's a tough one. Anybody have any thoughts on here in the group? RJ?
Yeah, I would say it's definitely not standard of care with one metastases to get the chemo. And I mean, it's mostly a burden thing where if they think that you have, or you do have a lot of metastases so that they can't treat those, it's stepping up the systematic therapy. And if you want to do that, one thing is to take ownership of your care and do the research and understand what are all the side effects. And the chemo is quite an intensive thing to do if you don't necessarily need to do it. But if you want to own that, and you know, like you know, do your research and you talk to the docs that you trust, and that's what you want to do, then you can do it, but it isn't standard of care. And so, like, I am doing that myself. So I just finished all of my radiation, and you know, now I'm starting chemo, but also I have 8 metastases, right? And so I actually got radiation treatment for all but one of them. And when I actually talked to the radiation oncologist, he said, I can't treat that one. Like there's not a way to lock onto it. I can't see it on the CT scan. It's in my rib. And so he can't do that. And he said, it is actually good that you're getting and ramping up the systemic therapy, because I can't treat that one. I don't know if, you know, that, you know, lumbar, you can get that treated if that's it's too close, you know. Probably that's something that they just want to do more systemic therapy. So maybe they're kind of like, well, if we ramp up the systemic therapy, but for one metastases, it's a lot. It's pretty aggressive.
Yeah. Yeah, I've researched, I've read quite a few articles on use of docetaxel. I just wanted to hear everyone else's thoughts.
Jen, we didn't ask you, do you have any other comorbidities? Are you in good health otherwise?
Yeah, yeah.
And how old did you say you were?
I'm 59 right now.
It's not, okay.
So what do
All right,
you,
well,
what do you,
I was just
what
going
do
to say,
you think?
I tend to agree with Rick and John that the second opinion is probably your best bet. Go ahead, Rick.
No, I mean, what are you thinking? Where are you coming down on all of this? And have you found anything regarding the use of the chemo with respect to large cribriform and IDC?
Yeah, I've looked for that. I've never found anything so far published on use of docetaxel specifically with cribriform. As has been mentioned here, it's always high versus low volume, high risk versus low risk. And everything I've found so far shows a benefit with high risk and with high volume, but no significant benefit with low volume. And I mean, my thoughts are with what the side effects of it would be. I think I would, if there's no shown benefit, I don't know if I would do it.
Have you asked Dr. Courtney why he's pushing the triplet?
The reason he said that is just because he said because I'm young and I have young children, he thinks that's just like going to give me a better chance.
Yeah, like I say, I've seen him treat like this before, and I'm just not convinced. And he likes chemo. He does like chemo. I've known men he's had on chemo. he's had men on cabazitaxel for years.
Yeah.
And this is one of the reasons why he's not one of my favorite docs.
Okay.
I wonder if we could get you a second opinion with Dr. E.
Well, I have already spoken with Velocic, so.
Well, no, I know that, but I would go with Belusic. But if you want another opinion, we've got a very, very good doctor in Houston, but she's about to move to Portland, but she's still going to see her patients, and she's still licensed in Texas.
Yeah, I looked her up, and where she was there at Houston Methodist, they don't accept my insurance.
Okay, well, you know, I think we like Dr. Belusic, so but then you I don't want you to have issues with Courtney down the road. You know, that's the problem. But
yeah.
So Dr. E will tell you that she has an anti-chemo bias, so you can pretty much be sure what her advice is going to be.
You're right. Okay. I didn't think of that, but you're right. Yeah. It isn't that she has an anti-chemo bias. She doesn't prescribe it readily because she recognizes the side effects. That's probably a better way to put it. And I think Belusic does too. Belusic is the sort of doctor, you know, Dr. Jack will tell you, and Don Rogers, he thinks about the patient. He's really concerned about the patient.
Okay.
That's good. Thanks.
Thank you.
Have we confused you enough, Eric?
No, that's good.
Keep
it's
coming
a tough
back.
call. You need more opinions. Okay, let's go to Dan in Schenectady.
I just had a quick update, just a couple questions about medications. I had the scan on Thursday to my lungs, and it was unremarkable, so I was very happy about that. And you've been talking about drugs, denosumab, Orgobox, and adabaterone. They're used conjunctively. I mean, they use except the same manner. And what's the difference between the two? In terms of side effects and all?
Orgovix, and what was the other one?
Adabaterone.
Oh, abiraterone. Well, Orgovix is an ADT drug. It'll keep your testosterone low. Abiraterone will do the same thing. It's more potent drug than the Orgovix. But basically, although they have slightly different mechanisms of action, they both will lower your testosterone.
Okay.
Abiraterone will lower it to just about undetectable. Orgovix might come close to that, but it could be anywhere, you know, under 10. Mm-hmm. Side effects would be more or less the same. You probably feel more fatigue with abiraterone and the prednisone.
Okay.
Anybody else want to? Jim Marshall, go ahead.
Well, let me first ask, what is your question? I'm not clear on your question. Are you looking at these as alternatives, or are you looking at these, or you're asking why you have to do both of them?
I'm asking why I'm on abiraterone with the prednisone.
Abiraterone, abiraterone.
Abiraterone. Okay.
Yeah, just call it Abby.
Okay. And the Orgovix, I was just wondering if there was a benefit of using the Orgovix instead of the abiraterone.
No, it's not an either. It's not in most cases an either or situation where you are right now. It is
Okay.
what we've been talking about, something called doublet. And
Right.
your diagnosis calls for both drugs to be used, at least to begin with.
Yeah.
So
when you say both drugs, you mean Abby and Orgovix or Abby and
yes,
prednisone?
Abby and Orgovix. The
Okay, 'cause I'm only
prednisone is just along for the ride.
Mm-hmm.
If you do abiraterone, you must do prednisone.
Mm-hmm.
As we know, as we know with your history, you got to do the prednisone. If you want to drop the abiraterone, you will drop the prednisone, but it's not recommended because the standard of care for you right now is to do Orgovix plus one other drug. Now,
Right.
we could talk about a different drug to abiraterone, in which case you wouldn't need the prednisone either. But if you're tolerating the abiraterone and you're tolerating the prednisone, that is the best way for you to start.
Gotcha. Yeah, because I got off the prednisone because it was raising my blood sugar. I got back on and my blood sugar really hasn't changed any, so that's a good thing. You know?
Okay. So if you cannot take the prednisone for whatever reason because of comorbidities, you have to come off the abiraterone and you have to go to another drug with the Orgovix.
Okay, like Gorvix.
Like what?
Gorvix?
No.
No.
Or
If
no.
you stay on the Orgovix, but we would add another drug instead of the abiraterone.
Okay, but I'm not on Orvix now.
I thought you said you were on Orgovix. What are you on right now?
Abiraterone, prednisone, I take Lupron shots.
And you taking shot? What shots are you taking?
Lupron.
Okay, so the Orgovix is an alternative to the Lupron.
Oh, gotcha. And how about duralutamide? That's an alternative to
abiraterone.
Gotcha, got it backwards. Okay. All right. And still, in my case, the abiraterone is a better choice.
We seem to think you get the most legs out of the LHRH drug, which is either Lupron or Orgovix, plus the abiraterone. That's what the research says.
Let's see, we've got Jim Marshall. Go ahead.
Yes, Dan. Anyway, I was on the 2 for 5 years.
Mm-hmm.
And I happened to tolerate it well because I was out essentially exercising, aerobic exercising, practically 5 days a week, and we're on a bicycle. Nothing strenuous, but just exercise, aerobic exercise for probably an hour a day. And I happen to tolerate it well.
Right, and that's at the point where I am now because I do water aerobics a couple times a week, and then I do some, bikes, stationary bikes, or in weightlifting, on the other days.
Fantastic.
Good
show.
Okay, gotcha.
All right, Dan, you're all set?
I'm all set. I'll just have one simple question. I talked to Dr. McHugh at MSK, and he's willing to take me on. And I haven't cut ties with my current doctor yet. And so I wanted to know, what is the likelihood if I was going to ask him, I say, look, I want to break ties with you, but I wanted to know if you would still agree to give my Lupron shots locally. I was wondering, what is the chance of him agreeing to that?
Where do you live?
And Schenectady, New York, Albany.
Oh, that's right, Schenectady. Well, that's a long drive. Yeah, I'm sure there must be a place you can get a Lupron shot without traveling all the way down to Manhattan.
is the doctor you're with right now, he is a medical oncologist, correct?
Yes.
Okay, what I think I would suggest to you is ask Dr. McHugh if he can set you up with a urologist in Schenectady who will give you the Lupron shot if you decide to stay on the Lupron. If you go to the Orgovix, it's a pill, so you don't have to worry about it. Okay? If you stay on the Lupron shot, most urologists are very happy to give you a Lupron shot because they make money off of it.
Okay. All right. All right. Yes. Okay. Yeah, so that answers my questions.
Okay, yeah, so that problem goes away, as Rick suggested, if you switch from Lupron to Orgovix.
Right.
All right. Okay. Looks like Robert Bogosian is next.
So when I was previously part of this group, I've had many tests, many PSMA scans, Exumin, MRIs. My PSA has been rising. All of the tests are negative. Just last week, I had an MRI. It's been 2 years for that. Again, nothing. And that was done at the request of my urologist who did my prostatectomy, which was Ash Tiwari. He wanted to do what I guess they call an exact scan, which is a transrectal MRI. They did that last week, and he saw 3 things on the ultrasound that he wants to do a biopsy. And I guess my question is with, is there an overlap or between the MRI and an ultrasound where, gee, if the MRI didn't show anything and the PSMA scans are not showing anything, what can an ultrasound show?
Good question. Anybody want to take that one on?
Well, I don't know enough about the exact technology. Does anybody, Dr. John, do you know about the exact technology? How does that compare to a micro ultrasound? Or is it a micro ultrasound?
I don't know if he's talking about a micro ultrasound, but micro ultrasounds have turned in some pretty good results lately and seem quite compatible, quite competitive with MRIs, but I don't know what is being considered here. Let's see what Dr. Russell has. He may have something better on this.
Well, I'm not a radiologist, I'm a surgeon, but there's no question there are times when an ultrasound is much more effective in diagnosing lesions, particularly for, say, gallstones, where an ultrasound is beats sometimes CAT scans or MRI. So I don't see how you can ignore a positive result. So I think I would probably take an action on that because they're very effective. And it all depends on the anatomy. In some places, an ultrasound is more effective than other imaging studies. So I think I would, I'd be hard pressed not to ignore the ultrasound result.
Okay, so I thought that Exact View was micro ultrasound, and it is. So essentially, what you've had is a micro ultrasound. And how would we compare a micro ultrasound to an MRI? Well, there is research on that, and the research suggests that the micro ultrasound is non-inferior to the MRI. Now, the benefit of that micro ultrasound is that it can see places where the MRI cannot. However, that is when it's done with a transperineal. You said he did it with transrectal. Is that correct, Bob?
Right.
Is that a yes?
Yes, that's
Yeah.
correct.
So I don't know how to compare a transrectal with a transrectal micro ultrasound with an MRI, because the reason the transperineal micro ultrasound does so well is because of the position that you're in, and it can see the anterior of the prostate, which you cannot see through if you do it transrectally. I think that probably, and he now wants to do a biopsy on what he's seeing. Is that right?
That's correct.
So why does he want to do and you've had an RP, a radical prostatectomy years ago, correct?
That's correct. No way.
So, and is your PSA, the last PSA we heard was 3.36. What's your current PSA?
4.3.
Okay. You know, I don't know. I don't know why Atari is. I'm not sure where he's going. I mean, at the end of the day, he's the surgeon. He's not Tawari, I should say. Tawari's the surgeon. He's not going to treat you.
Correct.
Right. So, to me, he's not the right doctor to be doing all of this. The doctor that I would think you want to be with right now is either a radiation oncologist, a really good one, or a very good GU medical oncologist. And you were holding off on your appointment with Dr. O. Where are you with that?
I was holding off until when I got the MRI, I said, there's really no reason to see Dr. O, because when I saw him last April, he said, just monitor the PSA. Nothing has really changed. So when Tawari wanted me to do this exact scan and now the biopsy, there's a very close relationship with Dr. O and Dr. Tawari, because Dr. O used to be at Sinai. And I suspect if I say, what do you think, Dr. O, he will defer to what Dr. Tawari wants to do, and
I don't think so.
Okay.
I don't think so at all. What do you think, Len? You know Dr. O better than any of us.
I'm having difficulty hearing Robert's voice. Is very low, low volume. You want to translate for me?
Yeah, I mean, what Robert said is that he thinks that since Tawari and O were both at Mount Sinai, that Dr. O will defer to whatever Dr. Tawari says. And my feeling is Dr. O is enough of his own man, and now, of course, he's now at Yale anyway, that Dr. O will give you his honest opinion as to what you should do next.
I absolutely agree with that. Dr. O is very independent-minded, and he's not going to be affected by any friendship he may have with Tawari.
Okay.
And
especially
what I would be doing before you go for another biopsy, because I don't know that we need another biopsy, and why put you through it? Other than that's what Tawari does, so he likes to do them. I would be going to Dr. O and saying, Dr. O, what do you think I should do next? And what do you think the treatment course will be? Do I need another biopsy? First of all, if he thinks you need a biopsy, why doesn't he give you a PSMA scan? That's a lot less intrusive. See, this is what bothers me with Tawari. He jumps in, and again, it's like we were talking before. These guys don't think about the patient. Now, if it may be that you don't make PSMA. You've had PSMA scans before, we've never seen anything, correct?
Many times. The last one I had was in January.
Right. So it's quite possible that you don't make PSMA. But that's a discussion to be having with Dr. O and asking what else can we do? You've had an Axumin scan before. Maybe we need another Axumin scan. But if Dr. O says, look, yeah, the only way we're going to know with you, Bob, is we're going to have to do a biopsy, then you go with a biopsy. But I would want a third party to verify that. It sounds to us like maybe you don't make PSMA, but we ought to then be able to see it on an Axumin scan.
Which I did have several years ago, about 2 months after the PSMA scan. My PSA at that time was about 1.8.
Right. So now you're at 4.3. So maybe we'll see something on an Axumin scan that we wouldn't have seen, that we won't see on a PSMA, because the likelihood is you're one of these guys who doesn't make PSMA, because we've done enough of them, we've never seen it. What do you think, Len?
Yep, I agree completely, Rick. I had PSMA scans that came up positive when my PSA was 0.17. And if you're at 4.3 and it's still not picking anything up, I would try another scan. And Axumin is a good candidate because any actively growing cell is going to pick up the synthetic amino acid, which is carrying the radioactive charge in Axumin. So I think it's a good choice.
We've got two doctors wanting to weigh in here.
Yeah,
Dr. Alfredo.
Yeah, I just wanted to state my comments about the ultrasound being accurate when other imaging studies are not, was not a recommendation for biopsy. Because I sort of agree with Rick. I'm not sure that it's necessary, but he knows more about this case than I do. But all I'm saying is that ultrasounds can be more effective in other imaging studies. So it's a piece of information, not necessarily need to be acted on.
Dr. Alfredo.
So I agree with Dr. Seneca, but I'm going to run the risk here of saying something unhelpful. I've been fortunate to have access to various specialties. And so what I think about in the context of this conversation is, in whose hands is the instrument? Who's ordering the test? Who's doing the test? And in my, again, data point of one experience, I've had to work with some interventional radiologists. So they're not urologists, they're not surgeons, but what they think about all day, every day is imaging. And they do things like they're interventional radiologists. They put catheters in people. They do it while the person is in the MRI in real time. They do ultrasounds. They do cryosurgery. They do a lot of things. So I would just ask the question, how experienced is the human who's suggesting the imaging and is going to perform the imaging in comparing the various kinds? The last 5 minutes, we've been having a debate about all the multiple ways there are to get a picture. Great. That's good to know. I also would like to talk to a specialist whose specialty is which kind of picture is most helpful. So that might be helpful to everyone.
Yeah, but see, here's the trouble. Here's the trouble. I don't want to say trouble, but with that approach, with prostate cancer, interventional radiologists are not generally used. There are your interventional radiologists. Usually there are specialized urologists who use particular equipment. So Tawari may be using the exact technology. We know that there are some good doctors in different parts of the country who are very experienced using micro ultrasound. I don't know enough about Tawari using micro ultrasound, but what I do know is that if you get a doctor like Dr. O, who's one of the best genitourinary medical oncologists in the country, looking at a micro ultrasound, I would trust his interpretation of what he's seeing.
Yeah.
And I might even trust it more than I would trust Tawari's interpretation.
Yeah.
And
Simply saying
so,
that I like the idea of a practitioner who has access to and training in all of these modalities and can actually make a judgment. That's really all I'm saying.
Yep.
Too many practitioners, they took a course, they learned to do one thing. The typical urologist knows how to do a transrectal ultrasound, and that's it.
Yeah.
That's not a criticism, it's just that's a limitation. So in this context where we're talking about the pros and cons of different imaging, I love a practitioner who says, oh yeah, I can make the judgment which is best, whether it's micro ultrasound or MRI or CT or whatever. That's all.
So I think our bottom line is, Bob, take a trip over to Greenwich and see Dr. O.
Yeah.
And send him Len's best regards.
Yes.
Yes, please do that. Okay, can we, Jim Marshall, I think you said you wanted time.
Yeah, just a short anyway update. Review here, diagnosed 2017, started Lupron plus, Abby and prednisone. I did that for 5 years until June of 2022. I took a treatment holiday, and at this point, I'm still on the holiday. 39 months. Testosterone got up to 55. It's now at 33. PSA took about 17 months to budge, and then it started to creep up. It has been up as high as 0.22, and now it's 0.12. And at this point in time, I think that's good. I'm on a sort of a phantom ADT trip at this point, I view it. And I am going to continue to ride this pig as long as I can. Thank you.
Thanks, Jim. Thanks for the update, and it's good news. So your PSA actually dropped a little bit, or almost in half, actually. Yeah.
Which was a surprise. I saw it starting to climb 0.16 to 0.22, and I thought, oh my God, where is it going now? And all of a sudden, back down to 0.12.
Yeah, I wonder if there's a correlation there between PSA dropping and your T level also dropping.
That's probably true. Dr. John, a comment I see?
Yeah, I got a question about that phantom ATP business.
Well, ADT.
Yeah, well, I know, I understand what you mean. So which is better, to have a phantom ADT, meaning you're simply not making testosterone and your level is 30 or 50 or 20 or whatever, or to have, or to be on a drug and have your level, your T level be 6 or 8? Which of those two is better?
Well, in the case was testosterone has probably never got below about 18 in the entire time. And I get
even when you were on active drug?
Yes, I was on active everything, and with Abby and let's see, Eligard. So I don't know. So at this point in time, should I go back on the Eligard just to knock it down to 6 at the time and where the PSA is still below like 0.4? I don't know.
That's my question. It would seem like you and me are doing great with low PSA levels, although and low-ish T levels. But is it better to drive it down even lower? The T, I mean. And I think there's some evidence that a T of 6 is better than a T of 20, even though both of them are completely castrate.
Okay. Let's see, we got a hand up. Larry, go ahead.
Yeah, thank you. Yeah, I've read some studies that differentiate the time to recurrence and time to progression. The lower you get on the testosterone, the better it is, and the longer the time is. But when you ask, is it better? That sounds more philosophical than medical. So I'm going to weigh in on the philosophy end. How are your side effects? Is it worth a little extra risk of not taking the drugs to have a better quality of life?
Well, I can answer that. And where the quality of life is before my triple bypass was quite good, even though, well, it had been good for 7 years. Okay, on the drug, off of the drug. And then where the triple happened to come in AFib, and there's more out of the AFib than there was from the prostate cancer. So it's a little hard to judge now because I've been slowed down to about, I'd say probably a third speed because of the AFib.
So I don't want to digress too much, but I have a question for you, Jim Marshall. Do you drink coffee? You drink coffee?
Decaf. And yes, I saw that a while ago in the JAMA thing. I saw that. And occasionally I will drink coffee. Actually, I drink green tea. But,
okay, well, see what happens if you try drinking some coffee, see if it helps your AFib. It turns out that my very good buddy, who I sent the study to, called me up yesterday and told me he was part of the study. He was actually in that study. And for those of you who didn't read it, what this study says, and it's from legitimate source, is that if you drink black coffee caffeinated, there is a lower incidence of AFib. This
Rick,
is for people
I thought it was decaf.
No.
I thought it was decaf.
No, it was caffeinated versus abstinence. One arm was caffeinated, the other arm was abstinence.
Hey, Gail, how about get out the coffee pot? Okay. Hey, amen, brother. I like coffee.
I know. And when I mentioned it to a doc that I happened to see for myself on Friday, and I said, "Did you see this study?" She said, "Oh, my AFib patients are going to love me for this one."
Yeah, for sure. All right, we better get moving here. Oh, we've got John G. has a question, and then Dr. Seneca.
Yeah. My understanding is that there are a lot of studies and meta-analysis showing that intermittent ADT is, in terms of OS, is as good as continuous ADT with improved quality of life. But that's just my understanding.
Yeah.
Just want to mention
Dr.
that.
Seneca.
Yeah, I just want to say I'm really impressed how much Rick reads, but I saw the same thing about caffeinated, and it's like, okay, just wait. Things will turn around. Things we once believed are no longer true. So yeah, what's bad for you will
Joe,
be good for you. But
Joe,
chocolate will always be good for you.
Job's comforter, Dr. Russ. Job's comforter. Let those guys who like a drop of coffee have a little bit of coffee and make them, and they'll feel good about it. That's what I say. Listen, I almost fell off my chair when Dave called me yesterday. And he said, "Oh, I'm so glad." He said, "I'm so glad you sent me that study." I said, "Yeah, you can drink coffee now." He said, "No." He said, "I was part of the study. I was waiting for the results to come out. My doctor wouldn't tell me about the results." He said, "They're not published yet."
Okay, you heard it here first, guys.
Yeah.
Let's see. Oh, yeah, we got everybody there. John G, did I give you a chance to comment?
Yeah, I just said
Yes.
that there's studies showing intermittent ADT is comparable to continuous ADT
Oh, right.
with better quality of life. Just that's it.
Right.
And also the movie Sleeper, if anybody remembers that movie Sleeper, where they show, one of the things in the future, they realize all these things that are bad for us are actually good. So like cake and stuff like that. Does anyone remember that movie, or am I?
Yes, I
Yeah,
do.
yeah,
That
I
was
remember
a
that.
great story.
Potato chips are really good for you, and ice cream.
Great movie.
Okay, let's see. Joe Commanda, go ahead.
Okay.
Steve White, go ahead.
All right. I don't think this is going to take real long, but I'll ask it. I've got two questions. I've been taking Orgovix for a year, and I really haven't had serious side effects, so that's good. This past September, I added Nubeqa, 2 capsules in the morning, 2 capsules in the evening for 300 milligrams a day. It's working, as was the other, but to my surprise, it has really knocked me back. I'm still exercising a lot, but I get a lot more tired. When I talked to my doctor, she talked about the possibility of cutting back on the Nubeqa. I'm kind of inclined to stay on it and try to get on top of it. So I'm not in a big hurry, but I wondered if you had any thoughts.
Well, I've cut back on Nubeqa on the times when I was on it. I haven't been on it in a year now, but when I was taking it and I was feeling some fatigue, I cut back to a half dose, and it kept my PSA down perfectly well. What surprises me here, Joe, is that your body reacts strangely to these drugs, because typically people get knocked down from the Orgovix, and then they add the Nubeqa, and they say, "Oh, it's fine. It doesn't. It's like I'm taking a placebo." But in your case, it's kind of reversed. So I guess everybody's.
Yeah, I know. Well, the doctor didn't expect I would have any trouble with the second one, so we'll see.
Yeah,
I'm hoping I can still get on top of that. So you found that we did cutting it in half didn't. Let me just ask. So you found that cutting it in half didn't really. That seemed okay for you.
For me, yes. It didn't affect my PSA at all. It kept it down to near undetectable for about a year.
I think
And then I
cutting
just
back
stopped
is a
completely.
fairly common practice, Joe.
Is it?
I think so.
Okay.
Yeah, Joe, I think there's another consideration here. That we know that the ADT drug is very cumulative. And whilst you didn't have much of a problem for the first year, which is great, it could well be that what you're experiencing is the result of the cumulative effect and not the fact that you're on 2 drugs.
Okay.
So it could well be that you could try doing what Len's done and what David Muslin has done and a bunch of other guys, which is see what happens when you drop the Orgovyx and you just stay on the darolutamide and see if that makes you feel better. And see what happens. You know, your testosterone will come back, hopefully, and the darolutamide will protect you, which is what's happened with Len and the other guys that we know have been on monotherapy, and see if that makes you feel a bit better. And that's probably what I would be, I'd be discussing.
Okay.
Notice also that ST in the chat has mentioned the estrogen replacement idea for down the road if we ever get to that.
Yeah. So ST, was that a replacement for the ADT or was it added on?
I used just an add-on because I was well into my ADT course and I decided not to switch. So I've been using the estrogen patch, and it made an enormous difference. Got rid of the hot flashes. I slept well. Got rid of the fatigue. Got rid of the dizziness. So it improved my bone health. So I'm a huge fan.
How did you know what dose to use?
Yeah, there's not much guidance on that. I did some lab tests from LabCorp, not paid for by Medicare, and kind of experimented. For me, the right one was about the middle of the road, 0.05 patch.
One of them?
Sorry, John, did you say something?
Just one of them? One patch?
You the protocol is you do 2 patches a week because it kind of wears out, it absorbs. So you take you switch patches every 3.5 days.
So you only had one at a time, right?
I'm sorry, I didn't catch that.
But only one at a time.
There's somebody talking in your background, so every time you talk, I can't hear you.
Len, you take it.
Okay. What is he's asking, you're doing 2 patches per week, but only 1 patch at a time, correct?
Correct, yeah.
Okay. All right. Well, I don't know. Should we stick with ST here, Rick?
I had a second question.
Oh, go ahead, Joe. Sorry.
Yeah. I've asked her how long she thought it would be before I became hormone resistant. And she says that the average is about 2 years. But when I listen to you guys, it seems like it can be forever. So I wondered if you could comment on that.
It's 11 years for me, Joe. Jim, I don't know how many years for you.
8 1/4, and I'm
It's
still
going, right?
castration sensitive. Of course, I was a 3-4, so.
Okay, well, I was a 4-5. I am a 4-5, Joe. Oh yeah, I always was suspicious of that 2-year mark. That I've heard that too, 2.5 years, something like that. But the experience in our group is that guys remain sensitive to hormones for quite a few years.
All right.
Certainly,
Well, we can't know. So,
Joe, I think the problem is that these docs tend to spit out numbers which are very much averages.
Right.
And I really don't know where that number of 2 years comes from because there aren't that many people that run through the ADT that quickly. And especially today, that now that people are on doublet, it seems like it takes longer. And I would go back to Dr. Catalia and say, what's the evidence for your 2 years? Where did you get that from? Because without us knowing where she's getting it from, we can't comment. Our anecdotal experience, as Len said in this group, is most people do quite a bit better. I mean, you know, we could ask for a show of hands. How many people here have been on ADT and remained sensitive to the ADT for longer than 2 years? You know, stick your hand up. If you have, go to the react at the bottom and let's see how many people we get. I mean, I'm only seeing 3 right now. There's got a 4. There's got to be more, 5, 6, 7. I mean, you know, it's going to keep going up.
Right.
So where's her 2 years coming from? Now, I'm not saying that she's wrong, but I want to know where she's getting that number from. It's like you say to somebody, well, I'm metastatic. How long am I going to live? And they say 5 years. Well, we know that number's an out-of-date number today.
Right.
But Joe, the bottom line is nobody can tell you how long you're going to remain sensitive to hormones.
That's true.
It's an unknown. Yeah.
All right, I'm done. Thank you.
Okay, we have some hands up, but was that for the hormone question or do you want to comment? Larry, I'll start with you. Or maybe you should put your hand down if you have no comment.
No, I have a comment about the estradiol question. How do you figure out what to use as a supplement so that your estradiol levels remain where they ought to be for a man? You know, somewhere between 15 and 50 is the normal range, that according to my lab. And when you have deficiency in estradiol, you can have some side effects like the hot flashes and the bone loss and such. So if you take a low dose of estradiol, you bring yourself back up to where you ought to be, because testosterone lowering also lowers your estradiol. So a low dose estradiol supplement fixes that with very few side effects. I myself, now this is an anecdotal story, I was using Orgovix for a while. I had several side effects that were, you know, not good. I switched to estradiol high dose, which lowers your testosterone very well and does not lower your estradiol. As a matter of fact, raise your estradiol above what it ought to be. But I have very few side effects from that. So if you want to know more, estradiolinitiative.org. That's all one word, Estradiol Initiative. That's the end of my spiel.
All right, thank you, Larry. Jeff, go ahead.
Yeah, I became castrate resistant 2.5 years. They say that the median survival is 2 years. Well, I've been 6 years past that. The thing is that they've been doing tests about it, and they've been finding that taking an ARPI, they've been using apalutamide specifically in some tests, extends the amount of time considerably. There doesn't, like other people see, there doesn't seem to be an end to it. If you're on an ARPI, it prevents the castrate resistance from happening. So that's what's going on with the clinical trials. At least they're doing. I know somebody who's in the one with apalutamide, and he's all right. Well, maybe somebody else has a comment.
Yeah, I've heard that too, Jeff. It's a good point. If you're on the second line hormonal agent, it does tend to prolong the time to castration resistance. Maybe that's why the figures that you hear 2 years, that's in the days when they just gave you ADT drug and not the second line drug. Steve L., go ahead.
Yeah, they started calling me castration resistant after a little over 2 years. However, the definition seems to have changed a bit over time. Mine was raised, to less than 1 when they called me castration resistant. And it seems like in some of the past studies, they were using a 2.0 over nadir as the line that they called you castration resistant. Yeah, and
Well, go ahead.
yeah, and for Provenge, they seem to sort of want to call you castration resistant very early on so that they can do the Provenge when it's most effective.
Yep, that's true. But I don't know, we used to say that if you had, what was it, Rick, 2 or 3 consecutive PSA rises on ADT, then you were castrate resistant, right?
Exactly. Exactly.
Okay.
I just wanted to mention that if you're interested in using estradiol, and ST's been down this path a long time, we've got a video with ST, and I'm going to put it in there, which was and Al Latimer was in that, Dr. John was in that video. You might want to take a look at it, and there are some good suggestions. But I think ST is probably one of our best qualified people to talk about supplementing, because he's been through it and he's done this for some time. But I'll put
ST is Stephen Schuler, is that right? Have you changed his name? Yeah.
Larry Schuler. What did I change it to?
No,
I'm on a new computer since the last time I had joined the group, and I, for some reason, it didn't take most of my name when I first signed in today, so I corrected my name.
So is that considered a low dose estradiol? What you were taking, zero? What was it?
Yeah, I was taking the low dose. So I was not on the replacement that I'm forgetting your name here, who was just talking about the high dose as a replacement.
Larry Schuler, but I have 2 L's in my name.
Oh, okay. Yeah. So, but like I said, I found out about it before the patch study was published, actually, and so that's kind of how I fell into it, and did it as a supplement rather than a replacement for ordinary ADT. But I've been quite happy with the results.
And no, you didn't get the usual side effect of breast tenderness or gynecomastia?
I did, and I ended up getting my breast zapped after it started. I don't know if Medicare would have paid for it unless it had already started. Anyway, but not bad. So I did end up getting my boobs zapped. So yeah, I think if you can get that paid for, and if you're going to go that route, I would recommend getting it up front rather than waiting like I did. But it's not really a problem for me.
Okay, thank you. Now, we didn't get to Steve White. I know we need to, I think we didn't get to him last time, right? Is Steve White still with us?
Yeah, I'm still here.
Oh, okay. Go ahead, Steve.
So this is really just a quick update. So I've now been, let's see, the history was, had my prostate out in 2016. PSA started rising about a year and a half, 2 years ago. It got to 0.14. So Dr. Wujatunga at University of North Carolina cited the SPORT study, SPPORT, that what would work best would be to combine Orgovyx with radiation therapy. So I've been on Orgovyx now for 3 months. Of kind of like what are the other men? I think Jim Marshall may have mentioned. I've been trying to do a ton of exercise, which has really helped me tolerate that well. And I've got now, I guess I'm have had 28 of 33 radiation sessions. So that'll wrap up in about a week. And again, I think the the amount of exercise I'm getting, which is pretty significant, and just trying to eat as much protein as possible to keep my muscle up. Those two things seem to work well thus far. So really was just going to offer that as an update.
And how are you feeling?
Pretty good. I mean, the side effects aren't ideal, but it's like worse problems to have than what I'm dealing with. So I can deal with it.
That's great, Steve. That's really good. That's really
and I
good.
appreciate all of the suggestions and advice that you've given to me, especially as it relates to the exercise, and then also that you give to others, which is all fascinating to listen to. So.
Yeah. And don't hesitate to take time. That's why we're here. We want you to tell us. Other guys are encouraged by what you're saying. So, and that's really important. So thank you for speaking up.
Yeah, appreciate it. Yeah, I mean, this weekend I ran a 5K race. It's like I'm pushing it pretty hard, but it's I tell my kids I'm not going to give in to the fatigue. When I get tired, I just push harder. So that's what's been working for me. Okay, so don't want to take any more time. Just wanted to give you that. Thank you.
So you've lost a couple of people along the way, Len. I don't know if you saw, but Stan Friedman.
Yeah, we had 44. Now we have 28.
Yes, well, Stan Friedman wanted time. He'll come in next week. Bob Y, I think has gone. He said he was having to leave. He had some issues.
No, I'm still here.
Oh, yeah.
I just had a couple of very quick questions, if I could ask them.
Go ahead.
Yeah, I have had an MRI and a biopsy. I have a Gleason score of 4 + 5 = 9. I had hoped to get the PET scan very quickly in Pasadena, but I'm stuck having to wait for the PET scan until December 5th at UCLA, which is my primary hospital. While I was hoping to get an earlier PET scan, I scheduled a second opinion with a urological oncologist, Timothy Daskovich at Cedars-Sinai. And I was wondering, my appointment with him is next week. Is it useful to see a second opinion urological oncologist without having had the PET scan, or is that appointment kind of a waste of time if he doesn't have also the PET scan research material?
I would say wait till you get the PET scan so he has more information.
That's a fair answer. That's why I wanted to check.
Anybody else?
No, I definitely would agree. I mean, who's the urologist you're working with at UCLA?
Nicholas Donin, Donin.
That's right. Yeah, and he that's right, and he gave you some bum information, as I recall.
Well, he sort of thinks I'm a good candidate for a prostatectomy, even though I have not yet had the PET scan. And I think that's a little, obviously, I agree with you that that's a little premature. And so I'm going to hold him off. I do have an appointment also with the radiological oncologist, Amar Kishan, next week. And I think I am going to meet him, even though I don't have the PET scan, because I just want to get the basic information from Kishan, because he's.
I think there's more significant issues here. I wouldn't bother with the Cedars guy.
Okay.
And I I didn't care for what Donan said to you, because if we go run the MSKCC, did you run that MSKCC as we suggested?
Yeah.
You know, there's a 93% likelihood that your disease is already out the prostate based on what we know.
Mm-hmm.
So he's telling you 50%, but it's probably even double that. But even more important than that is this really significant crib reform research that was just published, which says that men who have crib reform introductal have a 25% likelihood of metastasis 5 years out if they do surgery, and an 8% likelihood 5 years out if they do radiation.
Yeah, so I think I need to wait for the PET scan and then talk to a radiologist, talk to an oncologist, and see what they recommend. I mean, it may be that surgery is useful followed by radiation, but I just don't know yet. Just don't know. Okay, I appreciate.
Well, I mean, you know, the question is, why would you do the surgery and then follow it with radiation? What is the benefit of putting yourself through all those extra side effects when we know that you're better off with radiation anyway?
Yeah.
And so that's really, and you know, I think that crib reform study is significant, even though what they reported, they didn't report it in as thorough a way as we would have wanted them to.
Yeah.
But I think you've got to show that it was a very reputable study, and they could have reported it in a better way. And it's almost like they're just giving us a taster out there of what it's about, but not yet. And I would be sharing that information with Donan and asking him. And if you do decide to go to the Cedars, Guy, I'd take it with you. But did you get, well, where are you in getting your slides reread?
Oh, well, that was I was going to ask you about that. Do you think that's a useful thing too, to get the biopsy slides reread by a second pathologist?
We said that last time. We think it's very, very useful, especially given what we now know about cribriform disease.
And you think either Ming Zhao or Dr. Epstein or Epstein?
Yes.
He's at Johns Hopkins?
No, he's not at Johns Hopkins anymore. If you scroll up, you'll find the details for both of them in the chat window.
I saw Ming Zhao, and I didn't
Epstein
see
is,
Epstein.
I think, right above that. He's with help me, somebody. What's the name of his entity now?
Advanced Uropathology Center, New York.
There you go. Thank you. Advanced Uropathology.
Thank you.
And it's right there. Dr. John put it in somewhere.
I think it was right below the information.
Right below it. Yeah, right below it. There's a telephone number, and that's the Epstein one. Yeah, he probably didn't put that in, but yeah, that's. So I would go to one or the other, and yeah, I think we need to really assure ourselves that that what you're looking at is definitely crib reform. I can't remember, was introductory part of your?
No.
No, just crib reform. Okay.
Yeah. Okay.
Well,
thank you very much. Thank you very much.
That's okay.
Okay. Thanks so much.
Okay, is Gary Martin still with us?
Yes, he is.
Okay, Gary, you're up.
Yes, just a quick update. Had my last dose of Taxol last week. I'm on the triplet therapy. PSA, I'm a high volume case. PSA initially was 62, went to 90 over about a month. And then last check, it's 0.35 just before the last chemo. Got the PSMA scheduled for early December, and I got an appointment with Dr. Schmier in Chicago mid-December. So that's all good. Thanks for those recommendations. Let's see, a couple of quick questions. Oncologist is suggesting Prolia for bone strengthening. Is that best for frontline, or should reclass be tried first? If anybody has input on that. The FDG, now radiologist on the PSMA was talking about that, but apparently you can sense neuroendocrine metabolic activity, but I didn't see that tracer was used. Is that standard with PSMA scans?
Sorry, did you say you were tested for neuroendocrine biomarkers?
Yes, I had a wet biopsy done recently. There were several. I think I forwarded those to Dr. John to put in the database, but I found some additional ones from the ctDNA that I had overlooked, and I'll forward those as well to Dr. John. I guess I'm just wondering and worrying about progression, to neuroendocrine.
So you are not. I if it were me, I would not be too concerned, because the response that you had to the docetaxel was very good.
Okay, good.
Is it perfect? No. Did you get below 0.1? No. Could you still get below 0.1? You might. Could you turn around after this and start to rise in about 3 months? Maybe yes. God forbid that happened. Then maybe you've got to start worrying about neuroendocrine. What the doctor's talking about is that there is something similar to the PSMA test, which is used to detect neuroendocrine. They use it for thyroid cancer quite often. They use it for pancreas. Do you need that right now? If it were me, I wouldn't be looking at it. It's not something, we don't have the indicators that you need to be worried about that.
Okay.
Now, as far as the bone strengtheners are concerned, if it were me, I'd be going with Prolia.
Okay.
Because it's a newer drug, and it's probably a better drug. Len, how would you compare denosumab to a bisphosphonate?
Yeah, I think that it's a pretty close comparison, but I think that the denosumab is somewhat more effective. First of all, it's much easier to administer. You don't have to come in for an infusion, which I think you have to do with the bisphosphonates.
Okay.
Just an injection once every, well, in the case of Prolia, once every 6 months, or you could get Xgeva, which is once every 3 months, and it's double the dose of Prolia. How many bone mets did you have?
3.
You only had 3? Yeah, maybe Prolia would be sufficient.
And reclass you can get as an injection.
Okay.
So,
the preference would be Prolia.
The Prolia is a newer drug, and the only thing with that Prolia, as Len will tell you, is that when you come off the Prolia, and that might be 2 or 3 years from now, you don't need to be on it that long because it has a very long half-life. But when you come off the Prolia, you need to close it out with Reclast or Zometa. You need to,
Okay.
but that's way down the road, right, Len?
Yeah, and just one infusion of Zometa to lock in whatever gains you made from the Prolia.
Okay. All right. Thank you.
Yeah, you don't want to just stop Prolia or Xgeva like cold turkey. You
taper.
quickly lose the benefits.
Okay. Taper off with the other med.
Well, it's not so much taper off, but yeah, you switch to the other drug.
Okay.
Yeah, good.
Thank you.
Okay, and Mark N, did we get to you yet?
Not yet.
Okay, go ahead.
Okay, quick update. I met with Dr. Greg, thanks to AnCan. I met with him last week. He's the surgeon at MD Anderson. He said everything, as far as they can tell, is contained within the prostate. That goes from a PET scan and an MRI. But he said these tests aren't perfect, so that's what they think now. He said I am a candidate for either surgery or radiation. Rick, you asked, I believe, can he treat intraductal with radiation, and he said that shouldn't be a problem. But I do meet with Dr. Tran on this Thursday in a couple days. So I need to make a choice between radiation or surgery. And Rick sent me a great read on cribriform, which I also have. And I'm just wondering what I should consider, because they've all got their own stack of side effects. I don't like any of them, but I've got to make a choice. So open to comments, suggestions, anything.
Go ahead, Rick.
Well, I think that the first thing is we've got to get a confirmatory reading on your biopsy slides, Mark. Where are you with that?
Oh, that's been done. Dr. Epstein did that a couple of weeks ago.
Okay, and did he confirm? Did he confirm that you have both intraductal and cribriform?
Yes, he did. And it's still a 4.3 is my worst one. I think the other one was downgraded to a 3.4, but I do have a 4+3 Gleason.
So you're a 4+3 with cribriform and intraductal.
Correct.
Which is kind of like the story we heard right at the beginning, right? Somebody else was Keith. Keith has a similar situation, but he wasn't intraductal, or was he? I can't remember. I'm getting a bit punch drunk here. First of all, Tran is very, very good. So, what I cannot say to you, what I really can't offer you an opinion on is how effective radiation is if you have intraductal. Typically, it's been said it isn't, and that was what Ben always represented to us, that with intraductal cancer, surgery is preferred. I don't know. I mean, I think you can listen to both of them, but I think you've really got to drill down on how effective each one would be in the context of your cribriform and your intraductal.
Okay, what Dr. Greg said was, I'm running back up to my notes here. He said, actually, they are going to do a third read on the slides. So the slides are bouncing back to Houston here because that's what they wanted to do. That's fine. He said the rated cure is the same for both surgery or radiation with me. It's just the side effects are different.
Yeah, but that doesn't take into effect the intraductal.
Well,
he's right. They are the same if you
Okay.
didn't have introductal. But what now he may not know because he may not have done a lot of work with introductal, but that's really where I feel like that you have to really drill down. You've got to find out how good radiation is for introductal.
I specifically asked him that, Rick, and I am looking through here for my exact notes. Because I specifically asked him about this, and it's one of my questions.
Mm-hmm.
Give me a second here. I'm running through notes. He did say we talked about nerve sparing, and I could get one full nerve spare on one side and a partial on the other side. Just how things are juxtapositioned in there. Let's see.
Have you spoken to Dr. Epstein?
Yes, I did.
Did you ask him if he had any input on which is a better treatment with introductal?
I did ask him that. I'll have to run up to those notes and look at it. I'm still getting. Sorry, I'm got all these notes here. I'm trying to read through them. Probably just missed it. Yeah, I'm not sure. Let me run up to Dr. Epstein here and see what he said, because Dr. Greg said it could be treated. That's what he said. I remember him saying that. So Dr. Epstein, okay. Dr. Epstein said not a lot of great data, not as responsive to radiation therapy. I may be better off with surgery. Right. That's what Dr. Epstein said.
And that's what we're saying to you.
Right.
We're saying to you that in the past, people have tended to do the surgery, and then if they needed to follow up with radiation, they did. We don't normally advise that. That's what we were saying to whoever it was before, Bob Young, who said, well, why don't I just do the surgery and follow up with radiation? Well, I don't think he had introductal. But if you have introductal, that's considered probably the gold standard to do the surgery first. Now, you've got to push Tran, who's probably going to tell you, yes, it's just fine if you do radiation. You've got to push Tran. But that's really where the rubber hits the rubber meets the road, and what's his name? The doc you saw, Greg, isn't it?
Greg, yes.
Yeah, what Greg is saying is, well, it doesn't make a difference. But I think we seem to think it does make a difference.
Okay.
And it's real hard. Especially, well, no, I mean, you're in the sweet spot for the surgery. I don't know. I don't know what to say to you. I don't. I mean, all I can tell you is repeat what we've heard before from, and you're hearing it again from Epstein, that, it's probably best to do the surgery and then go on to do the radiation, but it's a tough
I will reach back out. MD Anderson, they've got a great online, you can ask questions and it'll get directly to Dr. Greg, even if I ask one of his nurses. So I will, okay, here's what he said. I found it. Okay, IDC can be treated with radiation. It's not better or worse when treated with surgery or radiation. It is a higher risk feature, needs to be treated, it is a little more aggressive. That's what he said. But what I will do is reconfirm that. And so I'll reach out and ask those guys the same question tomorrow.
Yeah, I mean, say to him that you have some input from some other people with IDC. You have some input from Dr. Epstein. He's going to know exactly who Dr. Epstein is. And, they're saying that it doesn't respond as well to radiation as to surgery.
Okay.
And verify and see what Dr. Tran says. And, give him that evidence, see what Dr. Tran says. We just
Okay.
want to make sure you ask the right questions, Mark. That's the most important thing for us.
Yes, thank you. I will do all that because I'm trying to figure this out. And I did ask Dr. Greg if I do radiation first and then the cancer comes back, can they remove the prostate then? And he said that gets tricky. He said it's a pretty morbid operation. So,
Yeah,
at
but
first I was trying to completely stay away from surgery. Now I'm kind of starting to bend back around towards it maybe.
Well,
So,
look, it's not the right question. You didn't ask him the right question. Can they do surgery after radiation? Yes, it is a messy operation, but it's done not fairly frequently, but it's not unusual, and a good surgeon can do it. But it is messy. He's absolutely right. The question you should be asking him is, are there alternatives to follow up with treatments to follow up with after radiation? And the answer to that is we think there are. Yes, there are other types of radiation you can use. This whole surgery radiation it's not a useful question. It's a question that it's something that the surgeons tend to bring up to sell surgery first. But today we know that there's a lot of alternatives for people who have radiation first, all kinds of ways we can treat them if the disease comes back.
okay. All right. I'll follow up with that as well.
What do you think, Dr. Russ? You're the surgeon. You're the surgeon in the room. What have you got to say about that, Dr. Russ?
Well, I've had problems with both. I had surgery in 2001 and ended up having to go back to surgery, had 25 units of blood, 13 units, 13 days in the ICU on a ventilator, multiple PEs, and then 7 years later had radiation, which now has created more morbidity with a contracted bladder with a low volume. So nothing's for free. I guess if I had to do it all over again based on that, I definitely would pick radiation and take my chances. I mean, the complications from surgery are just significantly greater, and it's a bigger deal. So that's the way I would, at least from what I hear from you, if we're talking about something that's equivalent, I'd take my chances without surgery.
Mm-hmm.
Okay. Huh. All right. I appreciate the input. Thank you very much. Thank you, Rick. Thank you very much for the guidance.
Pleasure. It's a pleasure.
Now you're
It's a
bending back
pleasure.
toward radiation, Mark, right?
Well, for this 45 seconds, I am. We'll see what I wake up and think about at 1:42 this morning.
Yeah. I don't think you can make a wrong decision here because of the introductal. If you didn't have the introductal, it might be a much clearer decision for you to make, based on the Memorial Sloan Kettering nomograms and everything else. The complicating factor, and thank goodness Dr. Russ didn't have to wrestle with this, or at least he didn't know he had to wrestle with this, because at that time they weren't looking at introductal. But the complicating factor is the introductal. And maybe what I have an idea as to something that we might be able to do for you, somebody for you to speak to, but I don't want to commit. So who had introductal and had surgery and then finished up doing the radiation afterwards, but is probably the person amongst us who knows the most. But he recently resigned from AnCan, and he's going through Pluvicto, and so the question is, I don't know whether he'd be willing to take on some navigation right now.
Fair enough. Okay.
Rick, it's time to wrap it up, brother.
Thank you.
Everybody-
Yes, you ain't
Yeah.
kidding. You ain't kidding. And Len, a special shout out for you staying so late. Thank you so much.
Well, thank you for helping out so much. And we'll see you next week, guys. Have a
Yeah,
wonderful.
we don't know who's moderating next week. Well, we've got to have a chat between the three of us and see who's going to take the responsibility. It won't be Len though. We'll excuse Len. He did sterling work. It'll be me or Dr. John. Okay. Because we're on the West Coast as well. The two of us are on the West Coast.
Good night,
All
everybody.
right, good night, guys.
Good
Thank you.